So now we just have two topics left here in immunology. First one I'm going to look at right here is Kawasaki disease. Back in step one, Kawasaki disease was discussed in cardiovascular pathology, and it was with the last few. Let me see, it should be right here with the vasculitides. Yeah, right there. Right, so although it was a pretty prominent topic in step one, it wasn't really that popularly tested. So here they just tell you Kawasaki disease, also known as mucocutaneous lymph node syndrome, and they tell you it occurs in Asian children under age 4. You note conjunctival injection, a polymorphous desquamating rash, which kind of just appears everywhere. There's a lot of pictures for it online. You see some cervical adenopathy, which is usually the first thing they'll mention, and often they'll try to start off questions with this. There's going to be a strawberry tongue, which really just gets mentioned as a tongue that's got some redness to it. They won't really show you, they'll either show you a picture or they'll actually just describe it to you. It's very rare for them to actually give a picture for this. And then some hand foot changes with like edema, erythema. And the most important thing here is the fever, right? Now here you can see they don't really talk too much about it. It's very minimal information about the actual presentation, things you're going to note in the patient's history, any of that. And they tell you that it can lead to coronary artery aneurysms, which would be pretty bad and can actually kill the child. These aneurysms can lead to thrombosis or rupture, and then that would just suck. So to treat it, one of the things that were notoriously focused on in step one was to give aspirin. Usually you should never give aspirin to kids. It's not really a good idea. It leads to a lot of bad side effects, but in this case scenario, aspirin helps, and the benefit to risk ratio is far too good, so you need to give them aspirin. Generally, if you do give aspirin to kids, they get Ray's syndrome, which can be also nearly fatal, but here that won't happen. That same reaction won't really take place because of their current condition. In CK, they focus more on giving the IVIG rather than aspirin, because in CK the question will be more so about actually bringing patients to the clinic, and in the clinic we can do better than just give them aspirin. But of course, not everyone actually has IVIG. If this is like an urgent care clinic or something, then aspirin may be the quickest thing they can actually provide to this child. But in the hospital setting, in the inpatient setting, IVIG is present more than often. Now in CK, they go into a lot more depth describing exactly what happens. So they say this is a multi-systemic acute vasculitis that primarily affects young kids, particularly those of Asian ancestry. It's divided into acute, subacute, and chronic phases. So already you could tell this is going to be a handful, right? It has 3 different phases to it. The same mnemonic is also mentioned here, but again, the burn part is very significant. The fever that they have is going to be very high fever, and it's going to last for a very iconic 5 days, right? It's also often just referred to as the 5-day fever disease. So the acute phase has 1 to 2 weeks from onset, right? In this phase, you're going to have issues that occurred in the child before they presented with rash, conjunctivitis, and really bad fever, right? The subacute phase is the slower, even longer phase. That's what subacute means, which is 2 to 8 weeks from onset. They're going to have these manifestations of thrombocytosis, elevated ESR from inflammation. Untreated, children may begin to develop coronary artery aneurysms. All patients should be assessed by echo at diagnosis. So doing an echocardiography at this point is extremely significant. The chronic phase is where now the real other issues come up. All clinical symptoms have disappeared, and the ESR lasts and eventually will return to baseline. So that means inflammation will return to baseline. Inflammation will go away. Untreated children are at risk for aneurysmal expansion and an MI. So if you ever get a tricky question where they tell you that a young child had fever for a very long time, maybe a week, as they might describe it, and then all of a sudden the child died of an MI, it's extremely rare for a child of, more than a 1-year-old child to die of an MI. Sudden cardiac death, which occurs in newborns and infants, is a different thing. But if the child is no longer an infant and they're over age 1 year, and then they had fever and they died all of a sudden, the first thing that should ring a bell in your mind should be Kawasaki disease. it will probably not happen that they'll tell you that the child is East Asian. Right? They're not going to tell you that. And if they do tell you that, they're not very nice about it. They'll tell you that the child just came from some East Asian country. So let's just say China, right? So they'll tell you the child just came from China. They all just immigrated from China, and no vaccination history is available. They don't have any information about the child's birth and how everything went when the child was born. And now they'll start trying to confuse you with a bunch of things regarding the immunizations. Is this rubella? Is this rubeola? Which one of these issues that we usually vaccinate or normally vaccinate people in America for? Is it one of those issues? And they'll try to throw in a bunch of things into the question. But the most notable thing is going to be the fever and the rash, right? So crash and burn really just sticks because of the crash word having rash in it, and burn for the fever. A fever and a rash, right, are also seen, unfortunately, in rubella, rubeola, and then, of course, the cervical adenopathy, also seen in rubella, rubeola, the measles and German measles. So differentiating this is going to be either based off of the type of rash. They'll have to tell you what kind of rash it is, or they'll have to maybe show you a picture of the rash, or they'll have to tell you that this all already happened. Now today the child is actually somewhat okay and is now in the chronic phase, at which point you need to do an echo, right? For CK, that's going to be the key thing here. They're going to require you to do an echo to make sure you can check the child to see how their heart is doing, and if they're having aneurysms, any of those symptoms like that. They go on to tell you the clinical manifestations right here, so you can see now what we're dealing with, right? So you see the hand and foot swelling, right? Very much like an adult would have edema in the feet, but adults rarely get edema in the hand. And in fact, overall, as far as kids are involved, there are none that I can think of right now, no real diseases per se that would cause edema in the hand like that. Okay. Also, the rash doesn't really have any specific pattern. It's pretty much everywhere, right? Pretty much everywhere. So they tell you you're bilateral, non-exudative, painless conjunctivitis with limb sparing. Right? So they have really bad conjunctivitis in both eyes. Oral mucosal changes like erythematous mouth, pharynx, strawberry tongue, or cracked lips. So usually they'll just tell you there's erythema, buccal erythema, or they'll describe some mucositis to you. And while reading it in the question, especially if this is your 200th question, it might not be that clear. Rash, again, no real way to describe it. It's just an erythematous rash. And it's polymorphous. It has all kinds of different shapes in different parts of the body, so there's no actual way of describing it, like, oh, all the rash looks like this, or all the rash looks like that. No. Some places it'll look one way, and other places it looks a different way. Right? But it is on the back of the hands and feet. So don't confuse it with being on the palm. It's not going to be on the palms and soles. It's on the back, the dorsal aspect of the hands and the feet. Induration of the hands and feet, erythematous desquamating. See, they write here palms and soles, but it's really on the back of the hand, not exactly on the palms. We have our CARS mnemonic, C-A-R-S, for Coxsackie A, C-A, right? And then R for rickettsia, S for syphilis. These are the only real things, at least as far as infectious disease is concerned, that cause rash on the palms and soles, all right? But again, in your question, they may go on to say it's in palms and soles, but it's really on the back. So they will hopefully be very accurate about describing where it is. It's not going to be on the palmar surface of the hands. Cervical lymphadenopathy, which is also not very specific because many diseases have this, right? But it is painful and unilateral cervical lymphadenopathy. Okay, so the presentation overall is pretty lucrative. You can't really, no one of these things, nothing here is actually very specific to this disease. You see these things in other diseases as well, which is what makes this a challenging diagnosis as well as a very important diagnosis, though, because if you don't diagnose this correctly, the child can die. Other manifestations which are not required for diagnosis include a sterile pyuria, gallbladder hydrops, hepatitis, arthritis, all kinds of things that can occur, which will of course further make the confusion in the question. So they tell you diagnosis for lab workup in the acute phase. You will see normochromic anemia, leukocytosis with left shift. That means you're going to see a bunch of baby versions of all the white blood cells because you're making fresh ones. A lot of inflammation, so there's elevated inflammatory markers like ESR and CRP, C-reactive protein. In the subacute phase, you also start seeing thrombocytosis, a lot of platelet problems, which is why aspirin helps, because aspirin is antiplatelet. And eventually, the inflammation decreases during this phase. Echo at the time of diagnosis is necessary to establish baseline for longitudinal follow-up. You need to see exactly how the heart is doing when this patient came in to see how that progresses, if it's getting better or not. Follow-up for uncomplicated cases usually at 2 weeks and 6 to 8 weeks after diagnosis to check for the chronic version. Best treatment is high-dose aspirin for the anti-inflammatory, antipyretic, and antithrombotic effects it brings, and IVIG to prevent coronary artery aneurysms. Now, they will never have an answer choice. You're lucky if they do that, where they say both things, to give high-dose aspirin and IVIG. That's the actual real treatment. However, by putting the answer choice high aspirin and IVIG, high-dose aspirin and IVIG, when you see that answer choice, it'll automatically ring a bell for Kawasaki disease, and then you'll start considering that, and then you'll re-investigate the question, and then of course you'll get it correct. So they don't do that. They'll either write aspirin or they'll write IVIG as an answer choice. Low dose aspirin is then continued, usually for 6 weeks, because of the risk of having a chronic phase to it. Children who develop coronary aneurysms may require chronic anticoagulation with aspirin or other antiplatelet medications. Patients taking aspirin are at risk for developing Rey syndrome, mainly in this chronic phase where they keep taking it. Corticosteroids may be used in IVIG refractory cases, but routine use is not recommended. So now, of course, it's a good idea to go back and kind of check out what exactly happens in Rey syndrome, because of course you can imagine they'll give you a question, you'll be reading it, you'll be very happy you're understanding that the question is Kawasaki disease, and then you're like, okay, give the kid aspirin, and then the next sentence says they gave him aspirin. So now you're like, shit, now they've mentioned it in the question, so what are they actually going to ask at the very end? And at the very end, they're going to ask, what is the child at risk of? They're at risk of Rey syndrome. So Rey syndrome, rare, often fatal childhood hepatic encephalopathy. So it's a hepatic encephalopathy, which we've seen presents with asterixis, too much hyperammonemia, stuff like that, associated with viral infection that has been treated with aspirin. Very common. Everyone has aspirin in their house. It's a very common medication that you can just buy over the counter. Sometimes what happens is moms and dads who weren't told by their pediatrician to never give aspirin to the child, their child may end up having some kind of viral issue, and the child is sick, and they'll just give the child aspirin because they didn't know any better. So then what do you find? Well, aspirin metabolites actually reduce beta oxidation by reversibly inhibiting mitochondrial enzymes. So basically, you poisoned their mitochondria. So that's their powerhouse. So then you're going to have mitochondrial abnormalities, fatty liver, hypoglycemia, vomiting, hepatomegaly, and possibly coma. Avoid aspirin in children except in those with Kawasaki disease, right? So SHINE was the mnemonic they had in step 1, and back in step 1 times in Sketchy Micro, they actually had a bottle of aspirin that had sun rays coming out of it to remind you of the shine aspect of things. Actually, I don't have the picture here, but try to remember what it was that they had Rey syndrome in. This kind of Sketchy Micro image was the. This one right here. So this image, as you can see, has this aspirin bottle right here. All right, and that sunlight on it with the child having the red turban on is to remind you the red turban for encephalopathy, right? And giving aspirin for all kinds of general sicknesses is very common, so that's what was happening here. This image itself was for the orthomyxoviridae. Let me just check real quick. So, I mean, obviously, you could see from the image here that this is going to be for the flu. They have it here, but mainly not the flu, for influenza. All right. So the influenza virus, influenza A, B, and C. So well, the flu, yes. Right. So for influenza, it's very common that someone's child gets a flu, and then they end up giving the child aspirin. Terrible idea. Not a good idea to do that. But some parents who didn't know any better do that, and then the rest of this image is here for very pathophysiological things that were questioned in step 1. We don't need to worry about the rest of that. But yes, so fatty liver basically, and that's the issue that sparks the hepatic encephalopathy. Hypoglycemia, which is further going to make the child more encephalopathic, and you're going to have a lot of confusion in the child. Not awake, so the coma, and encephalopathy is the main thing. Most of this mnemonic, in my opinion, was always a little unnecessary. The main thing you need to remember is just Rey syndrome, you're not going to have that sun ray shine in the child. The child loses their shine. Now they're going to look very dull and knocked out, like they're asleep, right? And that's because of the encephalopathy that precipitated from the turning off of acyl-CoA esters, actually, right? So what happens is when you do this, when you reduce the beta oxidation, you end up having too many acyl-CoA esters, and that actually is what's going to lead to hepatic injury. So that was the very specific thing you needed to know for step one. In CK, it's just important to remember that when they say there's a risk of developing Rey syndrome, that they're saying there's a risk of developing hepatic encephalopathy. All right, so this Kawasaki disease question can lead you to a question where they're asking you, oh, okay, so what should you watch out for in this child in follow-up appointments? There's two things. One, you need to check how their coronary aneurysm is progressing. Hopefully they're not having coronary aneurysms. Second, you need to see if they're getting hepatic encephalopathy. So hyperammonemia is going to be noted. Asterixis may be seen in their hands shaking like a really weird way. And at that point, you would have to, of course, discontinue the aspirin and try to fix them, with lactulose or something to get rid of the hepatic encephalopathy. You would have to go back and check all the treatment things that you do for hepatic encephalopathy. Some of those things may actually help, and they'll feel better. So here on the left, on the right side, they tell you Kawasaki disease and scarlet fever may both present with a strawberry tongue. Remember, scarlet fever also had strawberry tongue, but they have a sandpaper rash on their face. That was another iconic feature of scarlet fever. Kawasaki disease and scarlet fever may both present with strawberry tongue, desquamation of the hands and feet, erythema of the mucous membranes. However, children with scarlet fever have normal lips and no conjunctivitis, right? They don't have red eyes, nor do they have mucositis, where the lips are all inflamed and burning. And the most notable feature is the 5-day fever, extremely high fever. Now, of course, with scarlet fever, the name has fever in it. They also have fever, but it's not going to be 104 fever, right? 40 degrees Celsius or 104 Fahrenheit. They're not going to have that level of fever. It'll be like 100, 203 possibly. And it's not going to be a fever that's lasted for more than maybe 2-3 days, because the parents usually bring them in by that time. Aspirin is only used for Kawasaki disease in the pediatric population in fear of a rare but serious condition called Rey syndrome. Although the exact mechanism is unclear, Rey syndrome results from mitochondrial injury and fatty degenerative liver failure, which leads to hyperammonemia and ultimately encephalopathy. So you need to get rid of the ammonia using lactulose. And that's the completeness of this topic. And then here there's a question on Kawasaki from CK. So you have a 4-year-old boy brought to the ED for evaluation of a skin rash that developed over the past 24 hours. So that should not have been the main focus of this question, but thankfully the next sentence tells you the main focus. He has had fevers for 5 days. So right away from rash and then 5 days of fevers, it's a giveaway, or at least the first thing that you should be suspecting or suspicious of is Kawasaki disease. And right now, right away, you should start jumping around the question and check what is his fever, right? So we'll keep going through. It says he has a history of epilepsy, and valproate was started 4 months ago. So now they're trying to confuse you with some things regarding valproate, because valproate can also cause some really bad side effects. His parents have chosen to delay his immunizations. So now they're also confusing you with immunizations, with the measles and mumps and rubella, with that MMR vaccination not being given. Now you're confused, right? Now there's many options that you can fall for. Temperature 104 F. So now you're further confirming your suspicion of Kawasaki disease. But understand that while reading the question, if you didn't have that suspicion of Kawasaki disease, you're open to falling into any pit, right? It's like a roadmap, and there's multiple forks. You have to know the path you need to take. Otherwise, if you're just going to be guessing between the forks, then anything can lead you astray here. Physical exam shows bilateral bulbar conjunctival erythema, which is not a feature of the whole MMR thing. And limbic sparing and no exudate. Mucous membranes are dry and the tongue is erythematous with prominent papillae, which the papillae on the tongue are the little dots on the tongue that make it a strawberry tongue. It's not just about being red, but also looking like a strawberry with the papillary seeds that are all around the strawberry. The posterior oropharynx appears normal. There is erythema of both palms and a faint erythematous rash on the extremities and trunk with prominent bilateral anterior cervical lymphadenopathy. So throughout this question, they have successfully listed out every single feature of Kawasaki disease. Labs show you hemoglobin that's a little low, so slight anemia. Platelets are 420K, higher than normal, so that's thrombocytosis. and leukocytes of 14,000, with most of it being 75% neutrophils, right? So you have a lot of neutrophil chemotaxis happening. And then they also tell you AST and ALT are both about 70. So liver enzymes are also somewhat elevated. All right. What is the most important next step in his management? And the correct answer was IVIG. They didn't have an answer choice that said IVIG and aspirin, which would be the ultimate correct answer choice, nor did they have just aspirin. Okay. So either one, IVIG or aspirin, may be given as the correct answer choice, and you have to pick it. They're not going to put both things together, as I said, because if you see an answer choice that says IVIG and aspirin, then that'll spark your thinking into Kawasaki disease, and your suspicion will recheck the question. He has Kawasaki disease as evidenced by his prolonged fever, conjunctivitis, mucositis, erythema, and rash, and then the labs he has. Symptoms typically resolve. They do. Usually, everything goes back to being normal, which is actually the dangerous part, because then they go into the chronic phase without really knowing there's no more fever anymore. And at that point, at any time, they can have coronary artery aneurysm and they can die, right? The spasm. So coronary artery aneurysms are a potentially fatal outcome, so IVIG helps reduce the risk. That's all. Right, so this question is not that Kawasaki disease is very confusing or difficult or something really out of whack. It's just something that has a lot of confounding differentials, so you have to be very solid on your other differentials. Make sure you know exactly what you're supposed to see in the MMR group of infections, and don't get confused with scarlet fever either. Scarlet fever, as we said, does not have the conjunctivitis. They're not going to have a palmar rash or whatever. None of that is going to be there. And then the last topic here was the juvenile idiopathic arthritis. Right, so juvenile, so you're going to see arthritis in a child. This is why this is in the pediatric section. This was also in step 1. We'll go back and look at it. An autoimmune disorder manifesting as arthritis with morning stiffness and gradual loss of motion that is present for at least 6 weeks in a patient under age 16. Extremely rare, right? This doesn't happen. We don't see this. Formerly known as juvenile rheumatoid arthritis, approximately 95% of cases resolve by puberty. But that's a long time to wait, depending on when this disease actually started presenting. Puberty may be 2 to 3 years away. More common in girls than in boys. The subtypes are described in table 2.13. So once again, we have some subtypes to look at, right? Pauciarticular, polyarthritis, or systemic onset. This was not in step 1. So pauciarticular, pauci usually means that's not heavily articular, like the opposite of super articular. So this means that it involves 4 or fewer joints, not that many, right? 4 or fewer joints, usually weight bearing, no systemic symptoms. Uveitis is common, and this requires slit lamp exam for diagnosis, which is often an answer choice that everyone tries to dodge. We don't really think of doing a slit lamp exam for almost anything really, but here you do it. Right here, you do the slit lamp exam, and then you'll know that they have pauciarticular juvenile idiopathic arthritis. It can have positive antinuclear antibodies, but it will not have rheumatoid factor. Nor will it have the more important rheumatoid thing, the anti-citrulline antibodies, which was very key and very specific for rheumatoid arthritis. Most common presentation of juvenile idiopathic arthritis, usually diagnosed in young girls, right? So the pauciarticular version. Polyarthritis, this one involves a lot more joints, right? So presents in 5 or more joints, generally symmetrically, and there are systemic symptoms, but not that many. It's very rare, but there can be some. So systemic symptoms include things like having fever, having a little bit of anemia, stuff like that. One of the anemias that they would have would be anemia of chronic disease, because this would be infecting them, well, not infecting them, but affecting them for quite a while, at which point their body might start putting their iron away. Rheumatoid factor positivity is rare, and young children may be antinuclear antibody positive with milder disease. Rheumatoid nodules may actually be seen here too, which makes this version really make you think of rheumatoid arthritis. However, you should be very careful in picking rheumatoid arthritis as an answer choice in someone really young. Rheumatoid arthritis we usually diagnose at older ages. And then the last one, systemic onset. Right, systemic onset version of juvenile idiopathic arthritis. This one has recurrent fever, hepatosplenomegaly, and a salmon-colored macular rash. No antibodies or factors or anything, but the joint inflammation is the main problem. Joint inflammation may not occur for months to years after systemic symptoms appear. Right, so this one is more like dreadful. It's a very long-term issue that will cause a lot of problems over time, and all 3 versions really kind of suck. None of them are actual versions that you want to suffer with. So here, actually, on this page right here, we see rheumatoid arthritis, right? Key things here with the HLA-DR4, the anti-cyclic citrullinated peptide antibody being the key thing for rheumatoid arthritis. And you have a lot of features in rheumatoid arthritis that you're not going to see there. And you're definitely not going to see any of those symptoms that made OA and RA very difficult, which were your extra articular symptoms, right? Symptoms that are outside of the bones, right? So like pneumoconiosis, lung disease, pleuritis, pericarditis. You could see anemia or chronic disease, but that's seen with anything that has anemia. Anything that has chronic disease. Amyloidosis, Sjogren. These things won't happen. These things won't happen in the juvenile polymyositis, and they discuss it right here in a very tiny area: systemic juvenile idiopathic arthritis. Systemic arthritis seen in under age 12. So you can imagine how long this could be for 5 more years before it disappears and they go into puberty. Usually presents with daily spiking fever, salmon pink macular rash. Arthritis frequently presents with leukocytosis, thrombocytosis, and anemia. A lot of inflammation. Treatment is just to give NSAIDs, steroids, methotrexate, or any TNF-alpha inhibitors. Be very careful if you're going to give somebody a TNF-alpha inhibitor, because if you give a TNF-alpha inhibitor, you get rid of their ability to make granulomas, which can then reactivate latent TB. So anytime you ever give anybody TNF-alpha inhibitors like infliximab, you want to make sure you check them for latent TB first, right? That's just a rule of thumb you have to follow anytime you ever deal with giving someone one of those medications. So that's kind of what they reiterate here as well. And then there's this question over here relevant to some of the topics we've been talking about, and longer than most questions are in the book. So this says a 2-year-old boy is brought to the pediatrician for a skin infection that started on his chin, rapidly spread to involve much of his face and neck. This is his 3rd such infection this year, and he's constantly plagued by sinus infections and bouts of pneumonia. So first thing that should come to mind so far is maybe the child has cystic fibrosis. There's no family history of recurrent infections. Patient appears uncomfortable. Dermatologic exam is notable for erosions coated in yellow crust that are widespread across the patient's face and neck. So that's one of the infections the child must have right now. He also has patchy white pigmentation of the skin, light blonde hair, blue eyes. Now this part gives away what the problem is. Right? The problem is that melanin is not being transported throughout the body. So what's the most likely diagnosis? Well, if melanin is not being transported, there must be a microtubule difficulty. So that's Chidiac-Higashi syndrome, right, which we just looked at in the last video. Chidiac-Higashi syndrome was right here, right? Autosomal recessive disorder, where they have a defect in neutrophil chemotaxis, so they can't fight the infections. And the real issue is microtubule polymerization not working. So without microtubules, you can't really transport anything from one place to another, and they get all kinds of infections. What they were describing in that question was an S. aureus or S. pyogenes infection. We wouldn't know until we know more information. They explain that Chidiac-Higashi syndrome caused by autosomal recessive defects and synthesis and maintenance of storage granules in a number of cell types, right? So leukocytes, platelet neutrophils, and melanocytes. In addition to partial oculocutaneous albinism, these patients experience hepatosplenomegaly, recurrent serious infections like S. aureus, Strep pyogenes, and pneumococcus. Syndrome is often fatal in childhood because of overwhelming infection that the child couldn't get through. I mean, you can see this 2-year-old boy has already been through too many infections, right? And depending on the health and management that the parents were providing and how quickly they actually dealt with it, things can get way out of hand, right? So that's the summary of that. Now, in general, you want to make sure you're able to get these questions right. You need to practice a lot of questions. And Shea Design here, one of our doctors that's joining the session right now, actually sent me a bunch of practice questions. So I'm going to go ahead and go through those. I'm going to sort them out. Thanks a lot for providing them. I'm going to sort them out, set them up, and then we're going to run through some of those together tomorrow morning session. I didn't have enough time to look at it today, but I'm going to set that up, make sure I can break it down for you guys, and then we'll get to actually see how these diseases all are differentiated from each other, because a lot of them present very similarly with the same kinds of infections occurring, and maybe one infection gave away what the actual diagnosis was, right? Because in general, these are all immunodeficiencies. So all immunodeficiencies often tend to have many diseases that are shared, many infections that are shared. But there's going to be some kind of infection that'll give away, oh, you got that infection, all right, I know what the diagnosis is. That kind of thing is going to happen a lot, right? So we're going to see some of those tomorrow morning. And of course, speaking of infection, the next topic goes into all the pediatric microbiology, pediatric infectious disease. Absolutely nothing in this section is brand new. So you have your acute otitis media, right? You're going to see bronchiolitis, croup, which is a huge topic from step one, epiglottitis, so we're looking at all the symptoms that occur in the mouth and throat area. Then they move over to meningitis, which is also a huge topic, ocular infection of the neonate, pertussis with the whooping cough, the 100-day cough, um, viral examples, all your torches infections, right? And now we're going to get to see our measles, rubella, roseola, all those guys, and we're going to have to learn how to differentiate their rashes from each other because they do share a lot of similarities in their rashes. So I have a bunch of pictures to help figure that out. I was preparing all this. And then I'm going to keep accumulating more practice questions here to be able to figure out all these infections as well. And we'll be done with that. So this section I'm still preparing the lecture for, so we're going to continue that tomorrow morning. We're not going to have a very dense topic right now to talk about. But for today, make sure you continue spending your time really getting down these infectious, not infectious, these immunological deficiencies. You really want to make sure that you can differentiate these and group them up in little sections the way they are. So make sure you get all the B cell disorders down first. Make sure you get your combined disorders. Then you move on to your pediatric phagocytic deficiencies. Get them all down. Group them however you need to. Memorize them. You need to know their key features, right? What infections occur, we'll get better at once we look at more practice questions. But once you get the key features down, regardless of the infections, because as I said, the infections that these immune deficiency children are getting are not going to be the easiest thing. But if you can know the exact features to really pinpoint out, then you might actually be able to figure it out. Like for example, retained primary teeth. They might give you a bunch of shit, but if they tell you there's retained primary teeth, it's Job syndrome. You're done. You don't need to worry about too much after that. Don't confuse yourself by trying to really get down what exact infection is each one of these related to. When we do the practice questions, you'll see that a lot better, and we'll do that tomorrow morning. So you guys have a good, nice evening, and then we'll continue on tomorrow.